Good morning, everybody, and thank you for coming and to our second session. This is Qhsc. We are providing this routine training in preparation of our medical mission for September 2022. The medical mission is from 9/12 for September 12 to September 23rd, and we are going to be in Dar es Salaam with the 3 hospitals, which include Muhimbili, Mwananyamala, and Buguruni. So we are doing this training before we get there, so people will have the theory background, and then when we get there, we do the skills or validation of skills. We do have expertise for this training. Last week we did have neonatal health, and that was presented by Dr. Msambichaka and Dr. Banera from Tanzania. And then so today we do have our esteemed doctors are going to be doing this session number 2, Dr. Fabian and Dr. Martha Mkonya. I'm going to let them introduce and say hi to you guys before we start. So the how it's going to be is like they have their sections, and then they're going to present first, and then towards the end they will allow questions. And so there are 2 ways of you can ask your questions. You can ask the questions through the chat if you post your question in there, and if it's related at that moment when the presenter is doing, then we can ask the question right in there, or we can just wait until the end. You can get the chance to unmute yourself and then come live, so we ask these questions. The idea is just to have the interaction from each other versus just sitting there and let them speak, and then at the end you switch off stuff. So without delaying, my name is Dr. Harriet Gaboni, and President and CEO of and founder of Qhsc. And we are aiming to train and educate healthcare workers, share our knowledges, learn from you guys, and you guys learn from us to improve patient safety. So this is our goal, and we want to make sure we share what we can. And also we do medical missions, so we do bring our donations to come and help us either facilitate our training or just share what we get from here. And hopefully we see a lot of you this coming September, and also we see you through this training. So I'm going to let Dr. Fabian Guido introduce himself for a few seconds, and then Dr. Martha also say hi, and then we start the training.
Hey guys.
Hello.
Hey, my name is Dr. Fabian Guido. I'm a pediatric hospitalist. So my main job is usually caring for newborn in the nursery and level 2 care nursery. Those are sick babies. I also attend high-risk deliveries. I'm also involved in caring of children or neonates when they come through the emergency room, and then admission to the hospital. I'm board certified both in general pediatric and hospital medicine in peds. It's glad to be with you guys.
Thank you very much. Very qualified for today's topic. I'm gonna let Dr. Martha Mkonya from Tanzania come and grace us out with her presence.
Thank you, Harriet, for this great initiative, and I also acknowledge the other members on the floor that have agreed and like to take part and share knowledge that will benefit like both groups, colleagues in US and us in Tanzania, so that we can save lives in the newborn in terms of skills and knowledge. And as you've introduced me, my name is Martha Mkonya. I'm a neonatologist based at Muhimbili National Hospital. So I'm also a lecturer at the University of Muhimbili. I'm mainly training neonatologists and residents, but also support training of the undergrad. Currently at Muhimbili, we've started fellowship training for neonatology, and we happily have 4 fellows. So 2 years to come, there won't be only math and neonatology based at Muhimbili, but there will be 5 more, which will be great, and that will make history in Tanzanian neonatology medicine. So I've been in the unit for the past 13 years, working as a general doctor, pediatrician, and now currently as neonatologist. I've been involved in research training, both in Tanzania, Africa, and I also partner with other global partners like Harriet is a big name now, but also Colleen, Sweden, and other parts in US as well in other projects. So I'm happy to be here and looking forward to a lot of learning and obviously meeting the big team in September when you come and visit our unit. Thank you so much for giving me this opportunity.
Thank you very much, Dr. Madam Kony. And she forgot to add on her very long resume. She also has been a consistent contributor for the QHSC. When we had the COVID, she was one of the doctors who have been feeding us information from South Africa and Tanzania, sharing what the best practice over there and with expertise from here. So thank you very much for ongoing support for QHSC. I just want to acknowledge Dr. Lydia Msambichaka. She did the presentation last week. Dr. Msambichaka, I want to say hi quickly and then we start, please. And Dr. Banel. Hi.
Hi, I am sorry I will not turn on my video because I'm actually off the road, but I could not miss this wonderful education topic. So I will just keep it brief. My name is Dr. Msambichaka. I am very happy to be here and I'm looking forward to what is going to be discussed today. And for that, I will just end there.
Thank you very much, Dr. Msambichaka. Dr. Banera also did present last week. Can you just say hi, please? And then, well, I mean, the reason I'm introducing those people, so you see those series, when you're watching those videos, you know who and who is presenting. Dr. Banera?
I'm happy to, I will be joining from our last class.
Oh, great. Very good. Thank you very much. We appreciate the last week training. Perfect. Thank you. Okay, without further ado, I'm going to let Dr. Fabian Guido share your screen and take it over.
All right. Again, good morning, people in the US, and good afternoon, my colleagues in Tanzania. So my part will be talking about neonatal temperature changes, and Dr. Mkono will talk about the glucose changes. Let's see. And that's both of us. And the introduction we just talked about, I have no financial disclosure. And the objectives for both topics will be to understand in utero and postnatal thermoregulation in newborns, looking at the impact of hypothermia in newborns. And Dr. Mkono will talk about glucose changes in newborns, infants who are at risk for hypoglycemia, and then also signs and symptoms of hypoglycemia. For introduction, and I think in the group last week also discussed about this, the significant changes happen when the baby is born. The transitioning from intrauterine to extrauterine life is dependent on all these significant changes on the pretty much every organ system. Almost all infants will complete these changes without needing any special assistance, but about 10% of them will need some form of intervention. Some might require a little bulb suctioning, some might require a little oxygen supplement to help them transition. And less than 1% of them will require extensive resuscitation measures. This may include endotracheal intubation, chest compression, or medication like epinephrine. So when the thermoregulation, we'll be talking about fetal thermoregulation, the perinatal transitioning. We'll also talk about neutral control of thermoregulation, non-shivering thermogenesis, mechanics of heat loss on babies, and strategies to help baby maintain normal body temperature. So in utero, the fetus depends on its mother for temperature regulation. The heat is transferred to the fetus via the placenta and the uterus. So the placenta and uterus temperature 0.3 to 0.5 degrees Celsius higher than that of the mother. So right after birth, when the infant is born, the temperature drops rapidly. So our job is to make sure babies don't get cold. And babies needed to maintain this neutral thermal environment as one of the key physiological changes. So the definition of thermoregulation is the ability to balance between the heat production and the heat loss in order to maintain body temperature within certain normal range. For infants, the normal body temperature is 36.5 to 37.5 degrees Celsius. And when babies are exposed to cold environment or too hot of the environment, both of them have significant consequences in terms of their metabolism, specifically babies who are born preterm or low birth weight. So cold stress in newborns increase the risk for morbidity and mortality. In rare cases, a few babies might be exposed to being too hot, but majority of the baby usual experience is being cold. So our goal is to try to keep the babies warm. So there are two mechanisms where baby will try to maintain their body temperature. One is to increase the heat production, and one is to decrease the heat loss. For increasing heat production, there's a mechanism is called non-shivering thermogenesis. As the infants usually do not shiver, so they have a mechanism to increase the body heat by metabolizing brown fat. The brown fat is found most in scapula, kidneys, adrenal glands, head, neck, heart, great vessels, and axillary regions. The thing about metabolism of brown fat requires too many ingredients, and that's oxygen and glucose. So if your baby is hypoglycemic, you could see this metabolic process will be affected. If your baby is hypoxic, this baby's metabolism of brown fat will also be affected. And the brown fat is usually stored in the third trimester. So babies who are born very premature or born small for gestational age, they do not have sufficient brown fat, so they're even higher risk for getting cold quicker. And then another mechanism infant will use to maintain their body temperature is to decrease the heat loss. And this is through vasoconstriction in the arms and legs. That's why we see babies when they are cold, their hands and feet usually tend to be cold, blue. And also increase the activity of the muscles, and then they flex. And this flexion helps the babies reduce their body surface area and decrease the heat loss. World Health Organization has classification for hypothermia in newborns: mild, moderate, and severe. Mild is less than it's 36 to 36.4 degrees Celsius. Moderate is 32 to 35.9, and severe is less than 32. So our goal is to make sure babies never get cold, but the minute you intervene, lower categories like mild and moderate, let's intervene and try to make sure babies don't develop severe hypothermia. Because once they get to severe hypothermia, definitely their metabolism will be affected. They won't be able to transition, and here's when you talk about morbidity or mortality. Who are the infants at risk for hypothermia? Preterm infants or infant with a low birth weight and small for gestational age. As we talked before, they do not have much of the brown fat, so a high risk for hypothermia. Infant with a surgical problem like gastroschisis, omphalocele, open spinal tube defect, also organs exposed, increased body surface area, that means increased heat loss. Infant who are depressed at birth or hypotonic, again, they don't have mechanism of flexing and decreasing their body surface area. Infant who is acute ill also affects their metabolism of fat and also other organ system. And these are the infant also getting easily cold. So our goal is when we identify these infants, we have to pay even more attention on them getting risk of getting cold. Term infant could get cold, but this is specifically the ones that we have to be careful. So consider checking body temperature the minute you feel or suspect infant might be cold. So make sure they don't develop severe hypothermia. There are 4 different ways babies will lose heat. That's called mechanics of heat loss. 1 is conduction, 2 is convection, 3 is evaporation, D is radiation. With the conduction, the infant is placed naked on cold surface. Like when we weigh the babies, if the scale does not have a cover to keep it warm, then the babies might lose heat that way. Convection, if the baby is laying near open window or door because of the breeze or draft that's going to blow through and then make the infant cold. Evaporation, which is very important because this one we encounter mostly at birth. When infants are born, they are wet, covered with amniotic fluid. When the water evaporates, also cause the body to lose heat. And then radiation, usually there's no direct contact. The infant is just laying near a cold object, either window, a wall, and the heat will radiate from a baby to that object. This is basically the description we just talked about. So evaporation is the greatest source of heat loss at birth. So when babies are born, we immediately dry. Ideally, we should have at least 3 blankets or towels. Get baby dry, throw the first one, dry the second one, dry the head, put the hat on, and then replace that with another dry one and do skin to skin with mother and cover both mom and baby. The evaporation could be insensible or sensible heat loss. With the conduction, baby is placed naked on a cold surface and babies will lose heat. Convection, infant is exposed to cold surroundings, air or a draft, while radiation, there's no actual contact. And with the radiation, is usually the greatest source of heat loss after birth. So infant is in nursery or at home, if the environment or weather is cold, the doors are cold, and then babies might lose heat that way. So what happened if an infant is cold? As we talked before, look on the right side. So if the infant is cold, there's activation of non-shivering thermogenesis, and this results in a metabolism of brown fat. So as the brown fat requires oxygen and glucose, so if there's an increased oxygen consumption, baby will be in distress, increased respiratory rate. As a result of that, baby will develop pulmonary vasoconstriction, and that's called pulmonary hypertension. Due to that pulmonary hypertension, there will be tissue hypoxia in other organs. Baby will try to maintain oxygen in vital organs, so vasoconstrict the peripheral areas. And due to cascade event, infant will switch from aerobic metabolism to anaerobic metabolism, which results into building of acid, the metabolic acidosis. So this infants who have cold stress, if you don't intervene, could be hypoxic, resulting in acidosis. While if there's increased glucose use, that will result in depletion of glycogen stores, and then they'll develop hypoglycemia. So just in short, if we don't intervene, baby is cold, stress, they have serious and potential life-threatening complication, hypoxia, acidosis, hypoglycemia. And again, if we don't do anything sooner, there's a risk of death. And the strategies to keep the infant warm, it's a conservation of heat. The most significant effect on the risk to the newborn of developing hypothermia is usual temperature of the environment during delivery and postnatal period. So the environment are cold, baby will lose heat, so try to keep the baby bundled and stay warm. World Health Organization has 2 interlinked procedures they call warm chain, and this is used as a standard of thermal care for newborn in both hospital and community-based settings. The goal of the thermal care is to keep newborn in thermoneutral zone. So these are the 10 interlinked principles of warm chain. One is warm delivery room. So the minute we are called to a delivery room, make sure the temperature in the delivery room is appropriate to recommended by WHO to be greater or at least 25 degrees Celsius. All the supplies like towels, hats, dress should be nice and warm. Also need to have warmth during transition. So immediately after baby is born, you wrap the newborn immediately after birth. Warmth during resuscitation. So if infant requires special resuscitation, they will move from mother to radiant heat source, and dry again, stimulate, put the hat if he is not on at that point. And if they're very premature infant, consider having a polythene bag or thermal mattress. Next principle is warmth by skin to skin contact. If infant is well, as we said before, once you dry and you replace the wet linens with the dried, immediately start skin to skin and cover both mother and the baby. In terms of early breastfeeding and rooming in, as I said, infants who are well, they should initiate breastfeeding within 30 minutes of birth. And that one has also been shown to help the baby maintain their body temperature. Warm transportation for infant who needs to be moved to the nursery. Then if they're able to do skin to skin with mother, that's preferred. But if you're not, then should be transported in an incubator. And if they're very premature, consider having polythene wraps or bag or thermal mattress. Postponing bathing. WHO recommended to delay bathing for the first 24 hours. And again, most of the time when we bathe babies, if the temperature of the water is not appropriately, we are more likely to stress them. Monitoring newborn temperature. So temperature should be monitored for newborns under the radiant heat source or before transfer to neonatal unit. So if we have baby under the radiant heat source also, if the temperature is set up too high, they might get too hot, or if it's set too low, they can still be called stress. So no matter where they are, we should consider checking baby's temperature regularly. And then of course, the last is training of healthcare staff, which continue audit and training. Again, just like another training, repetition is always good. And I think about my section, the next part is going to be Dr. Nkoni to talk about glucose changes.
Before Dr. Nkoni takes over, I appreciate Dr. Fabian Guido for that theory base and for the examples. And so anybody who has question, please gather your question after Dr. Nkoni finish her presentation, but then we can ask those questions. I mean, I have already like 5 questions to ask, but I'm gonna wait until Dr. Nkoni finish her part first. So that was excellent, thank you. Dr. Nkoni, take away.
Thank you, Fabian, for a very nice presentation of the first part. Actually, in neonatology, I say we have the big 5, and the number 1 is like thermoregulation. And hypothermia, it doesn't matter where you're in Africa, where it's said to be hot, or in the Western world, where they can get really cold winter. If you don't have means of controlling temperature, the babies might succumb to hypothermia, and it has a serious complication, as you mentioned. We are going to tackle the second complication, which is the glucose changes, or complication that can lead to hypoglycemia. So again, I don't have any financial disclosure, but I must say I'm addicted to babies, and that is why I'm here. So in our presentation today, we are going to see on the fetal and postnatal glucose changes, transient neonatal hypoglycemia, risk factor for hypoglycemia, and signs and symptoms of hypoglycemia. So when the baby is inside mommy, the easiest way of understanding it, they get everything from the mother, and they don't have to worry about how their sugar is going to be. Actually, the fetus is a good parasite to make sure that everything that the mommy has would make it available for himself. And for that reason, they have a good supply of glucose and other metabolites like ketone fatty acid and amino acids, and they get to meet their requirements, whether they can manage to store or not, but they're not going to starve while they're inside. The problem starts when you cut that supply, and that happens when the baby is born. So the cutting of the cord disrupts this flow, and suddenly this lovely creature that in the land of plenty is being transmitted survival. And some of the changes would occur in the first 1 hour. And that is why for us, we need to monitor the glucose levels and assist the baby. And not only for premature babies, but even the healthy term infant will sort of experience a transition time, the first 2 hours, where they get hypoglycemia. And most of the time, this is asymptomatic. I usually say when you don't know what is happening to yourself, usually like you don't know what is happening and you tend to chill out. And if you go and start screening these babies, you find their sugars, okay, now it is low, so what do you do? But the baby is not complaining. So what happens after birth? So when the baby is born, that land of plenty is no longer there. So if the baby was term had adequate stores, then they'll have glycogen in the liver, and they'll start the process of breaking that glycogen into a useful sugar that they can use. And that process goes like glycogenolysis. The Latins again want to complicate stuff. And then you'll get glucose, and also it will enhance fatty acid oxidation in case you don't get like if you don't have enough glucose. But as I've said, when you are swimming in a land of plenty, at times you don't get time to store enough food, or you are used to just consume whatever that we have because you know there's always a supply. And for that reason, the babies will just use the whole glucose that they have in the next 12 hours of their life. And that is when the problem will start. But again, the insulin will be a slight on a higher level, but this is because there's like always mommy's blood is full of glucose, and the insulin is there to metabolize the glucose. And but after some time, the glucose will start going down. And for this reason, because the babies are used to be in a land of plenty, the WHO recommends to start feeding immediately when the baby is born. And because they know what they need to do, if you take a newborn baby and put it on the breast, on the chest of the mother, they'll crawl towards the breast. I think they get a good lessons while they're still inside. And they'll find the breast and they'll start latching. From experience, if a baby is allowed to latch and start sucking in the first 1 hour of life, this baby is not going to have issues with feeding. And obviously, science is telling us that it's not going to have issues with hypoglycemia. But what happens when we separate the babies from the mothers? They don't activate their sucking reflex, they don't get the glucose, they deplete all the stores, and that is when the problem starts. And we start seeing that problem for about 10% of the babies, and the glucose will go down slowly. And this is the silent one. The baby is nicely sleeping. You might think this baby is a quiet one, you are lucky. But if you check the glucose after 6 hours, it is 1.7, and you don't have a line, things could be in a mess. And what I've just said is actually a transient neonatal hypoglycemia. It's actually physiological. The glucose will fall down slowly, and then after some time, the baby will learn the lesson that, okay, I need to learn to feed and get out of this mess. And that is the physiological nadir of hypoglycemia. And sometimes it can go as low as 1.4. And after you start feeding the baby again, so the glucose will start going up, and that is when they get to manage to stabilize their glucose level in a range of 2.5 to 4.4. For those who are used to the other unit of 45 to 80, that's the unit that you're looking for. And when we are talking about hypoglycemia, it's when you have, excuse me. So neonatal hypoglycemia is glucose levels of less than 1.6 in the first 1 hour of life, and 2.5 thereafter. The first one, like in the first day of life, we allow it because we know the baby is going to have a transient hypoglycemia. But after 24 hours, the baby should have learned its lesson and start feeding, and we don't allow low glucose. But it doesn't mean when you have low glucose, you don't have to react. So why do babies get hypoglycemia? Some of the babies are at more risk. Not everybody is having a land of plenty. If mommy had a pregnancy-induced hypertension, had some sicknesses, the baby might be slimmer, not fatter or chubby like me. So we call that intrauterine growth restriction. And at times they just don't grow as what they should have. They cannot attain the appropriate weight per age, and we call them small for gestational age. So the baby is 10, the other one is chubby like me, but the other one is small. So small for gestational age. That means this baby did not have enough glucose while in utero. So if you see a small baby in a delivery room, open your eyes big, because they might have hypoglycemia if you don't act. Another one is, these are the chubby one, the spoiled one. They have everything more than what they want. The IDM babies, infant of diabetic mothers. Their moms have a lot of glucose and they tend to take it all. And the large for gestational age, they accumulate so much. So because they are used to a lot of glucose, and so is their insulin, it's always on their ceiling board. And once that supply is cut, the insulin takes time for its level to go down. So the little glucose that is available, immediately it acts on it. And because of that, they tend to go into hypoglycemia more than the appropriate for gestational age babies. The late preterm, you're not a preterm, you're not a term baby. I mean, like you're expected to be big, like you're 2.3, but you're not big enough. So don't assume this baby have enough. They've not accumulated their wealth of glucose, and they would succumb to hypoglycemia. Preterms, it goes without saying, they're busy making up their lungs and their heart and their GI system. They don't have time to store glucose. Glucose is being stored when you have made everything right. And if you are forced to come out before you have established yourself, you're not going to have any savings. And for savings for babies is glucose. And that is why they'll succumb to hypoglycemia. If I ask myself today to run for 10 kilometers, probably I won't. But if I see a lion chasing me, I might be the next Usain Bolt. And for perinatal stress, the babies, when they are coming out, it's like, it's your birthday and then you have to fight for your life, imagine. So that one, they use all the energy that they can get, and the energy means glucose. And because of that, because they're trying to breathe, they're trying to make their heart beat, they're trying to make their body warm. I mean, like, it's too much to start on your birthday. And that will consume all the glucose they have, and that will predispose them to get hypoglycemia. So this is what you have seen. And we said preterm, late preterms, IUGRs, they have a decreased glycogen stores. They have less adipose tissue. If you look at their skin, it's very thin. It is hanging, and even the enzymes that are supposed to make glucose, the gluconeogenesis, as what the Latins want to call it, they're expressed at low levels. Like everything you feel as is small, and so is your enzymes, and so is your glucose, and so you get hypoglycemia. And then if you're chubby like this friend of mine here, you have been used to be in a land of plenty, so is your insulin, and the moment you cut that supply from the placenta, your endocrine system is not accustomed to little glucose. So the little glucose that is available now from your own stores, it is highly consumed, and the baby will go into hypoglycemia. And that is why once you have a chubby baby like this one, I was actually born by 4.3. I don't know if my mom had enough milk or I had hypoglycemia, but watch out. One thing I know that I was good with breastfeeding. I even breastfed with my young brother. He was still learning. Yeah. So we talked about the perinatal stress, yeah? This thing would happen in a case of a fetal distress. Perinatal ischemia, you cut the oxygen supply. Maternal preeclampsia, eclampsia, you don't have a good supply to the placenta, to the umbilical blood supply. You have sepsis, you have hypothermia. That one would consume all your glucose. Why? Because you say you have the increase in your catecholamine, think of your adrenaline. And then that one, if you have a high catecholamine secretions, what it does, it increases your metabolic energy requirement. At the end of the day, the free fatty acids are inefficient, and then you have your hypoglycemia. And this is the cycle that I'm referring to. Or you can have a predominance of norepinephrine, resulting into minimal glycogenolysis induction, ineffective mobilization of glycogen storage, and you end up into hypoglycemia. I usually say when you're stressed, you cannot utilize your energy adequately. And that is why you have, if you don't want to talk too much science. So what are the signs of hypoglycemia? This is what it tells us, but most of the time these babies, before they develop hypothermia or sweating, they're just nice and sleeping. And be mindful of a baby that is just quiet with a nice heart rate of 110 and trying to go down, and the temperature is slowly dropping down. At times you might see a little bit of a sweat. And since these babies are in a closed incubator, you might not know. Or if it's last in an open incubator, you might think the overhead warmer is hitting the baby so much, but that baby is actually losing its glucose. At times, they don't have even energy to drink or to breastfeed, and therefore they have feeding difficulties. They have a poor suck. Imagine you are depleted with energy to an extent that you cannot feed. Or maybe it's because the baby that had a perinatal hypoxia, and you ask the mom to breastfeed, you ask the mom to be with the baby. They cannot suck, they cannot replenish their glucose, and they'll go into hypoglycemia. If they cry, for example, you do something and the baby wants to cry, their cry is very weak. You don't even realize there's a baby crying next to you. They're floppy because their tone is depressed. And the brain is very selfish. They want to use all the glucose. And for that reason, they'll present with apnea. At times you might have cyanosis, grunting, and tachypnea. So a baby presenting with respiratory distress, mind you, that is a good exercise for the baby. Try and see the glucose levels as well. And when you have used it all, you start having tremors. I don't know, I also get that one when I haven't taken my lunch at a reasonable amount of time. I start shaking and I know I need to get a little bit of glucose. And so are these babies. You'll see them like they're a bit jittery. That is what I call it. And if they've not acted, they'll start convulsing and they'll just lose it into coma. So as we have said, some of the colleagues, they went and do some studies, and Lucas and colleagues suggested that blood glucose levels of less than 2.6 is a critical threshold. It is associated with adverse neurodevelopmental outcome. So it's not just a problem of seeing a low sugar, but it doesn't only end during the neonatal period. Don't act on it. You might have a long-term neurological developmental outcome, and that you can start seeing at the age of 6 months, 9 months, 18 months, and so forth, if you have time to follow them up. And infants that have been experienced hypoglycemia on more than 5 or more, from day 5 or above, at increased risk of neurodevelopmental impairment. Therefore, what I want, like from this slide, what you can take-home message, if you have admitted a baby in a neonatal unit and this baby is persistent presenting with hypoglycemia, you have not either one been able to address it adequately or was referred to a unit late. Somebody was just giving bolus, the sugars goes up and then down, hypoglycemia again, up, down again. Is as good as having beta asphyxia, or I can call it like a mean diabetic ischemic stroke in an adult. So hypoglycemia, low sugars have ischemic changes on the brain, and that is why you have neurodevelopmental impairment. So it's not something that we'll see now, but you're going to see it later. But hypoglycemia, as I've started my presentation, it's usually transient. In the first 24 hours, it's something that you can get, but it should not persist. And once it goes beyond 48 hours of life, for example, if seeing the baby tends to have hypoglycemia, you have increased the feed, you have put the baby on IV fluids, but the baby is not improving. If you stop that one, you still like you are working on a thin thread of low glucose level. As a clinician, you need to start looking for other causes of hypoglycemia, such as hyperinsulinemia, and this can be established if you do the appropriate test, or inborn errors of metabolism, which will not be covered on this discussion, but later on, maybe Harriet will arrange that one for us. So thank you very much for listening, and these were my references. Yeah, back to you, Harriet.
Thank you very much, Dr. Mkonyi. That was a very good education for us and a good review for people who are working in those areas. So I am gonna invite questions from the audience or attendees. There are only 10 questions, I'm just kidding. So we welcome any questions. Please let us raise your hand, or let me put this. Raise your hand so we can see you and learn from your question. Anybody? Anybody? Oh, I'm sorry. Dr. Mkiwa Akida, please.
Afternoon.
Good afternoon.
Thank you very much,
Good afternoon.
and Dr. Fabian, for the good presentation. This was very good presentation for me, and it was very important to be in this continuous medical education. So mine is not a question. I have more of explaining the more important of these thermoprotection guideline. For me, I did my study in thermoprotection guideline, and I did a study in Dar es Salaam, and it was to assess the risky factors associated with hypothermia in regional referral hospitals in Dar es Salaam. So you can imagine with the temperature of Dar es Salaam, the hot climatic condition, but I got a prevalence of 25.6% out of the newborn involved in the study. So you can see the importance of healthcare providers to know the importance of WHO thermoprotection guideline, the so-called warm chain. And as it was presented by Dr. Fabian, this is 10 steps of thermoprotection are interlinked procedures. So when you disrupt one of the content in the warm chain, you expose the baby to neonatal hypothermia and development of hypothermia. So it is very important for us healthcare providers who are dealing with babies, the one who are working at labor ward, postnatal ward, post-Caesar, neonatal, and even in theater. You see from the presentation, Fabian said the delivery room temperature should be maintained at 25 degrees Celsius. And it is important also, if you find the temperature is not at that temperature of 25 degrees Celsius, the warmer should be on to make sure the delivery room is warmed. And if there is fans or air conditioning, should be switched off or regulated accordingly in order to avoid these newborn babies to develop hypothermia. So I thank you very much for the presentation, and I insist my healthcare providers who are dealing with babies to be aware of these thermoprotection guidelines in order to protect these newborn babies from hypothermia. For example, one of the complications of hypothermia is hypoglycemia, yes. And from my study that I done last year, I found among those babies who developed hypothermia, almost 5.8% develop primary complication of hypoglycemia. So we see the importance of protecting these newborn babies. And fortunately, I did the study in 10 newborn babies. We know most of the time we say the preterm babies, small for gestation age babies are the ones who are at high risk. But believe me, in my study, I done in 10 babies, and still I found the percentage of 25.6% of those who develop hypothermia. So I think we need to be aware of the thermoprotection guideline. Thank you.
Thank you very much.
Thank you, Dr. Akida. That was very good. Yeah. Yeah, I mean, it's important to know. I mean, I don't know, most people think living in a hot country, you don't have to worry about that, but babies do get cold no matter where you are. So it's very important, because once you run into hypothermia, then you deal with hypoglycemia, and then it's just like event and after event, and you don't want to run behind.
Thank you very much, Dr. Nguido. Dr. Mkonyi, do you have anything to add, or we can welcome another question or statement?
I think we can allow another question.
Okay. Any other question or statement sharing your best practice?
I think Dr. Msambi-Chaka has her hand up.
Oh, she's okay. Dr. Msambi-Chaka, thank you, Frank.
Hello, can you hear me?
Hi.
So I wanted to say thank you very much to Dr. Fabian and Dr. Mkonyi for this wonderful, very practical presentation. And my question is, oh, by the way, Dr. Mkonyi, I want you to be my lecturer for all my other educational aspects, because I'm very pictorial and visual and story-like, and I just could follow you very, very well and listen to you the whole day. So my question is, it's very easy to identify the at-risk newborns and probably have protocols in place to address early recognition of like hypoglycemia or hypothermia. What would you say would be some of the challenges that we might experience if for the babies that do not have, who are not considered high risk in terms of like, if I'm a new nurse or a new doctor on the ward and rounding, any challenges that you can think of for those babies, and some of the best practices that you can impart as we take care of these newborns?
Thank you, Lilia, for a good question and a comment as well. So I usually tell my colleagues in neonatology, less is more. and we use our eyes a lot. So one thing you need to observe the baby. When it comes to glucose, that means it's food. So see the baby, is the baby feeding? And not only that, the baby is latching, try to observe how it's latching on the breast. Is the baby swallowing? Is there something that is coming out? That can assist a nurse or a doctor to assess the breastfeeding. And the baby might latch nice on the breast, but is not breastfeeding nicely. There are different scores. For example, I'm used to a score where if a baby is having a score more and is breastfeeding nicely, and you might not have to worry much. But sometimes be mindful, there are babies that lie. They might lie that they're sucking, they might lie that they're swallowing. They have a cleft palate down up there, and they're just pretending that they're swallowing, but nothing is going in. And we know at times moms have challenges. Not everyone has a fountain of milk on the first day. So be mindful and watch it out. And thankful to science, they have a thing called glucometer. So 3 hours, check the sugars. What's your first level? Is 2.5. Okay, it's not good enough. It's not bad, but it's not good enough. See again after 3 or 4 hours. That is working in Dr. Lilia's unit. I'll first observe, but also apply a little bit of science, check those levels, and then assist accordingly.
Dr. Mkonyi, you are coming in and out, and I think when you're talking about the score for latching on, I didn't get the number. I'm sorry. What was the number?
So
you're looking?
Yeah, it's a tool that was developed in one of the hospitals that I've been, and it has 5 or 6 parameters that you need to assess. So a baby that is breastfeeding enough to go with mom is a score of 10. Less than that, we have to work on it.
Okay, thank you. If you have it, you can share. Then when we post this video, then we can make sure people can see what you are referring to with the scores. So then we can try to build the best practice and share that knowledge. So thank you. Dr. Fabian, did you want to say something? Or?
Yeah, so in response to Lillian's question about challenges, I mean, I could see one of the big challenges just to try to maintain room temperature, because it depends on the resource. Certain areas, I'm sure they'll have AC or heater to control the temperature. But if a baby is born in a very rural area, I mean, most of the time the windows are broken. So it's hard to maintain that. So trying to find the curtains to block the wind from outside. Then the other thing I feel it's going to be a big challenge is having warm, dry towels or blankets. There are certain areas in the world where people have access, they'll have 5, 6 blankets they can just use and throw away, and someone will take care of that. Where other places, not everyone have all this resource. So, I mean, one suggestion would be if the family could bring some and just have them ready before baby's born, keep them somewhere warm, so that when the baby's warm, when we're drying them, try to not to stress them. And then another challenge, of course, for healthcare providers to have the knowledge and know hypothermia or hypoglycemia, it's bad. So if your baby is laying there, doesn't mean necessarily they're not expressing stress. I mean, they might maintain their body temperature while they're trying to use every brown fat they have. And then once that crashes, and then they get really cold and sick, and unfortunately, we might lose some of them. So some healthcare workers, of course, try to educate ourselves the importance of hypothermia, and then also when we talk with the families when they go home, try to emphasize the importance of keeping the baby warm, and of course just remind them not to overheat the babies. Now, you don't want a baby get covered and then overheated and other risk for suffocation, because some babies, they get too covered, then it's more dangerous. So just enough to keep the baby warm.
Excellent. Before I forget, for everybody who has attended, if you can put your name and email on the chat, so then when we send this the recording and the questions afterwards, so we can send it to the right people and make sure we give you credit that you came and share your knowledge and learn from the presenters. So if you can just put your name and email, that would be great on the chat, and then we can respond to that one. Thank you. Any other questions? Go ahead, Dr. Benera.
Okay, thank you. I would like to thank you, Dr. Martha and Fabian, for their nice presentation. Mine, I'm not sure if it's physiological or not. The first one is for peripartum stress. I thought Dr. Martha talked about the risk factor for hypoglycemia. One of them is said the perinatal stress. So I've seen babies who fail to establish spontaneous breathing, and somebody will take maybe 5 or 10% glucose, inject it through the umbilical veins or artery, and then the baby will start crying. So I'm wondering if we can put it as a routine. Every baby who is not spontaneous breathing, after birth, you can check the RBG and take appropriate action. The other question is, what is the role of not breastfeeding, and then the baby develop a fever, and the mother is just told that you are not breastfeeding, you expose the baby, try to express more milk, and the fever will go up. I don't know, what is the physiology there? Thank you.
I think you addressed Dr. Mani or Dr. Fabian.
I mean, I could address the second part, the temperature, and Martha will do the hypoglycemia. Yeah, I'm not sure what they mean by baby has a fever, but I have seen some babies with what we call dehydration fever. If a baby is dehydrated, they'll present with a fever. We have had some newborns here in the US, and babies with a true fever within the first 28 days of life, they get full sepsis wake up. And I have several of them, and mainly it's dehydration. Mom goes home, the breastfeeding is not going well, baby's dehydrated. Then when they come here, the electrolytes are all messed up, but all the sepsis wake up, come back normal. So that's one thing, but I'll err more into caution. If a baby has a fever, instead of just saying babies just need to breastfeed, just make sure we are not missing baby who is sick with sepsis. But yeah, so there is a thing of when the baby is very dry, they develop high temperature.
Dr. Mkonyi?
Yeah, thank you, Fabian. So a dry baby, you can be dehydrated. And one of the things that can account for that one is you don't get enough milk, and it's something that would happen. And that is why if you go to the WHO recommendation, a baby after it's being born by a normal delivery has to be observed in a facility for 24 hours. And the importance of that one is to allow mom to connect with the baby and support breastfeeding. And then the postnatal follow-up should be after 3 days and 7 days. On the third day, you want to see how is the breastfeed going. Are the breasts engorged? Is the mom comfortable with the breastfeeding? And then on day 7, also early signs of jaundice. And then on day 7, how is the cord healing, and how is the puerperium with mom? And how do they find this newborn that they've just started? So yes, breastfeeding is very important. And at times I've seen it in my little time of practice in pediatrics in Tanzania. Babies are superly covered. I mean, like a temperature of 32, they have this blanket from granny, that nice jacket from daddy, and a kanga from shangazi. So everything goes to a baby, and yeah, the baby really gets those miliaria rash. And once you open the baby, when they come to the clinic, like they think you're an angel sent from heaven. So a lot of things can explain, but yeah, feeding is one of the things that can explain dehydration fever. So newborn stress, baby comes, score of 2, 3, baby's flat. What do you do? ABCD approach. And of course, don't forget to check glucose. I understand at times we have limitation in our setting and we do it all and then we cannot measure. So what do you do? Should I just let the baby go or give something at least so that I can know? So there is that practice that I've seen it. People tend to give glucose because their hands are tied and they don't have means of supporting the baby. And my advice would be the best practice is when you are receiving a baby that is coming flat from the neonatal unit, and I think it's one of the elements that we're going to learn or to remind ourselves in these sessions. Follow the ABCD approach, assess the airway, assess the breathing, support the circulation, and see your glucose. What is the glucose level? If your sugar is 5, don't give bolus. It's not going to help. The baby is flat because the problem is on the brain and it's not because of the sugar. Yeah. So should I recommend that one? Only when the baby is hypoglycemic. I wouldn't put it as a recommendation. And again, also because I was talking about glucose, how much should you give? It is 2 mils per kg if at all the baby is having hypoglycemia, because you don't want the sugars to go like whoop, 10, and then next thing you check it is 2, and then another bolus 10, 15, go back to 1. So you're going to hover around if you're giving too much boluses of glucose. Yeah, thank you. I hope I've answered your question.
Dr. Bonnier, she's asking you. Oh, she did. Okay. Thank you, Dr. Mkoye and Dr. Fabian, for responding for that question. That was an excellent.
Am I allowed to share this one? Sorry.
Yes, please. Go ahead.
Can we see?
Yes, we can.
Yes.
So that is what I was talking about on the breastfeeding assessment. So there is latching. Do you hear the baby swallowing? The type of nipple, the comfort, and then the hold of the position. This is the different one. So if a baby is having a good score for each, then it is 10, and this is the baby that is breastfeeding well. But if a baby is having whatever parameters that you can assess, then you need to assess the mom accordingly. So there are different parameters that have been designed. This is something that we are trying to implement at Muhimbili, but there are some of these parameters that are available in other places as well.
Okay. Thank you very much for sharing that. Dr. Msambichaka, is your hands up there or is from previous?
Yes. Yes.
Okay, go ahead. I'm sorry.
If I may, I was going to try and see if I understood part of Dr. Benella's question was the baby. We're talking about the newborn period and the baby having quote unquote fever and being taken away from the mother. My impression would be it is possible for the baby to be too warm if you're doing skin to skin and you're bundled up with like multiple layers of clothing, and that can be interpreted as a fever. But in most cases in newborns, actually hypothermia is more indicative of infection than hyperthermia. So it would be very unusual, like for a 3, 4, 12, 24-hour newborn to have a fever, because most of the time they do have hypothermia when they're under stress, even from infection. So maybe if you could clarify what you meant by why are they taking away the baby because of the fever? Is it that the baby is warm or hot while they were on mother's chest or while they were in mother's arms? Because I think that would address that's a whole separate answer than the dehydration hyperthermia that would be like typical of what we would see.
Dr. Benia?
Yes, what I mean, if the baby has a fever, hypothermia, we tend to take away the clothes we expose the baby. And then the rest, as I said, continue breastfeeding, expose the baby, and then the fever will go out.
Okay. So it's what we were talking about, where it's just like they're overheated because you have too much, and yeah, taking away the clothing to just kind of cool them down, or maybe if they had a hat, to take off the hat, or you have one layer of clothing. But I would caution that this kid should be monitored more closely. Like this, we're talking about, minutes to like probably an hour, the baby's temperature would regulate, instead of like hours leaving the baby exposed.
So another thing, if I can add, I know probably Fabian mentioned it, mom is actually a natural incubator that can regulate the temperature according to the baby's temperature. Dads cannot do that. So if a baby is having pressure instability, I know Fabian is laughing, just put to the mama's chest and mom will regulate naturally the temperature to suit the baby's temperature so that it can normalize. If you put it on a daddy's chest, it's only temporarily because the baby will just feel warm, and then the baby will cool down, and then they'll start getting cold again. So most of the time we don't get to see baby getting spikes of fever when they're in KMC position with mom, unless something is truly wrong. But yeah, so the incubator, the natural incubator, mom incubator, actually can regulate his baby's temperature very well.
Okay, thank you very much.
Yeah, one thing to add, I think the timeline is important, because baby with a fever right after birth, it could also reflect the mom had fever. So if that's the case, it happened within an hour after baby was born, just make sure they check mom's temperature, because mom is running a fever, then there's a high risk for choreo. That means baby also need wake up. But if a baby having a fever, I don't know, 6 hours of life, I agree. If it was overbundled or closed, then you can address, and then you can still continue skin to skin, and then recheck temperature in an hour. And then the babies who are coming from home, like 2-3 days of life, they have a fever, think about sepsis. I mean, it could be they're overbundled, but if they look sick, they need to wake up.
Okay, excellent. Thank you. Any other questions? Wananyamala, Buguruni, you guys are in groups, so thank you very much for bringing more people in there. So any questions from the other attendees? So one of you guys can say something. While people are thinking, Dr. Mkonyi, do you have, or even Dr. Fabian, do you have like just a review of the hypoglycemic protocol? So let's say I'm a nurse, I'm taking care of this baby, I realize the glucose is too low. What do I need to do, like right now, step by step, probably the first hour, 2 hours, 4 hours from now? What are the things that you want me to pay attention? What are the things that you want me to notify the physician or call the doctor in if I know I could not fix? Dr. Mkonyi, Dr. Fabian.
Yes.
Well, yeah.
Thank you. So if the baby was nice and go on, Fabian.
Go ahead, Martha.
So if the baby is nice and quiet, asymptomatic, and you've done a good job and find this baby is hypoglycemic, first thing I'll say, feed the baby. And by feeding, it depends on what the baby is supposed to get for that day. Is that 2 kilo baby, give the feed for that day for that at that time, and then check after 30 minutes and see what are the numbers. If a baby was planned to get, for example, to be started on IV fluids for whatever reason, then give IV fluids. You check again, the sugar is still low, I'll put a line, but I'll also feed the baby. And when you put a line, I can probably reduce the amount of feeding and then maybe give half feeds and then give IV fluids. So you start running the baby on a continuous feed. I get a second read, but obviously, mind you, when you do that, remember calling your doctor so that they can start working it out. 2 readings of hypoglycemia, the baby is not responding. I will probably increase the fluids for that day for that age. And then the doctor will come in and start doing some further workout. Might be the baby requires a little bit more. For example, it's an IGR baby, or it is hyperinsulinemic, and the baby needs a little bit more concentration of glucose than what the baby is getting on day one. Or there's something more, it's an IBM baby, is used to a lot of glucose, and we're just giving a little bit less of what he's used to. And if it's an older baby, for example, day 3, day 4, Fabian mentioned about hypothermia, the baby is hot, think sepsis. So this one I'll also think sepsis. Why is my baby requiring slightly more than what is required? And then the doctor will need to sort out in terms of investigations and try to like do a thorough assessment to see what is wrong. Fabian, if you want to add.
Yeah, I mean, basically just what Martha said. I mean, if baby is hypoglycemic, you identify that, you intervene depending on the protocol. Most places, as long as the baby is asymptomatic of mild symptoms, you could feed. You could either feed by mouth, but if they're premature baby, they're not feeding well by mouth, one option is consider putting a nasogastric tube and then feed the baby. And then recheck in 30 minutes. If it's still low, you could feed, but at that point, physician need to be notified. And then the babies who are in distress, having issues, the breathing, then you might consider the NG feeds or start IV fluid immediately. Because if the baby is tachypnic or grunting, then try to feed it by mouth with a high risk for aspiration. So if the baby is symptomatic with respiratory distress and hypoglycemic, it's either NG feeds or IV fluids. Try to avoid PO feeding.
Okay.
And then I'm sure at some point we'll probably have a hypoglycemia talk, and then we'll talk in details and what intervention is to be done in the workup. But yeah, I agree. If you see baby is hypoglycemic, don't wait. Just intervene quickly, because the next thing is baby's gonna start developing seizures, and as Martha said, it's a long-term complication. You might solve the problem with hypoglycemia, but if it had been hypoglycemic for 2-3 hours, I mean, they might go home looking normal, then at 6-9 months of life, they are behind on the milestones. So the sooner we intervene, then we help them don't develop long-term complications.
Okay, thank you very much. So what happens if we're trying to feed with the breastfeeding and mom doesn't have milk? Do you guys have like a donor milk, or do you use the formula, or do you use a D5 or D10? Whatever mom doesn't have milk.
So in Tanzania, the human breast milk bank is on some stages of development. Maybe next year when we have this talk, we might have a different discussion. So we give alternative to breast milk. That can be formula. In places where they don't have an alternative to breast milk, they might go for IV fluids. And may I take this opportunity to say IV fluids is by the cannula, not rectal.
Okay.
If I can quote my teacher, Professor Karim, he said we feed by our mouth, not through the rectum.
Okay. Thank you very much, Dr. Mkonyi and Dr. Fabian. Any other questions? Yeah, as what Dr. Fabian Guido was saying about the hypoglycemic, it's more involved and it's more details, and we may need a different session specifically for hypoglycemic. Then we can run those hypoglycemic protocols to see best practice and what we need to do. Actually, I can run through the scenario and have examples where what the physician needs to do, what the nurse needs to do, and what the communication between them means, like notification, clinical finding, and other stuff needs to be shared while you're trying to address, because the time is not on our side if baby is hypoglycemic. As what Dr. Martha Mkonyi was explaining, the effect on the brain, and then what Dr. Fabian was saying, when the baby is getting cold, then the temperature is going to start dropping and all those stuff. So We're going to add more sessions for different topics. And for those who attended this training today, if there's any specific topic that is related to what they're talking now and we need more information, let us know. And that's what the reason when we send the survey for knowledge assessment, there's some questions right there. What else do you want us to include on this discussion? So we can address and share best practice and be able to improve our clinical practice. So there is training in 2 weeks, which I'm going to post again once we finalize the time and presenters. They're still working on it to make sure to see who is going to be ready quick and we announce who they're going to be. There's possibility of fetal monitoring for people who are doing the obstetric side to make sure we monitor the baby and prepare for delivery. So, and if what are the risk factors or indications that we need to identify in mom. So then when baby is coming, one of the issues is hypoglycemic, we need to address that, anticipate if mom has those risk factors, then what are we going to be preparing for the baby? And what the preparation include for us to make sure we are ready for this baby. The other topics, including postpartum hemorrhage, other topic including ventilation and more into help baby breathe. So all those are topics coming, so stay tuned. We're going to keep sending this list of topics so you can be involved. Share those links to people so they can come and learn. It's not only just for the 3 hospitals, any healthcare worker who wants to come and learn is welcome. And then the reason also we want to know your names and your email so we can create that list of attendees. So when we have this education, we don't want you to miss. And when we start offering this in US, we call CE or CME. In Tanzania, I believe you said, what is that point? They have
CPD points.
CPD point, thank you. I wanted to say PPD, I'm like, that does not sound right. CPD points. That's why I hesitated. Yeah, so for Tanzania, for the CPD points, once we get application stuff ready, so then everybody who is attending these sessions will get those points, so at least you can count toward your professional development. So that's why I want to make sure, I don't want to miss anybody who attends and then you don't get credit for it. So we are working on it. So any other questions? And if thank you very much. Before I close, Miss Victoria Jones, you have your hand raised.
Yeah, I know this is kind of at the end, but I just thought about this. I have a niece who is expecting, and my question is, how likely is it for the baby to be have a high glucose if the mom has gestational diabetes? I'm just thinking about this. I was like, let me get this question in before they close.
You brought the right question to the right people in the right forum. So I'm going to let the expert is finishing up with that question. Thank you, Ms. Victoria.
Thank you.
Thank you, Ms. Victoria. So actually, most of the time if mom is diabetic and if they've managed to control the glucose right, then the baby might not have any sugar issues because the baby is used to being a normal sugar levels. But if the mom was having very high sugar levels, it was not controlled during pregnancy and the baby comes out, then what would happen? The baby's sugar levels might go a little bit low, and for that the doctors need to monitor. So this is the baby that will have to be stay in a hospital depending on where that mom is. In Tanzania, for example, might be admitted in a nursery so that they can check the sugar. In other places, the baby will stay with mom, encourage feeding, and the sisters will need to check the sugars to see if it is getting lower or not. In that situation, they'll probably encourage what we call guarantee feeding. For example, in day 1, the baby might have to take maybe 10 mils of milk, and the nurses will have to make sure that much is going if baby cannot latch well. So we'll ensure the baby is feeding, and we'll be monitoring the sugars 3 to 4 hours, or at least 24 hours before we can say everything is okay.
Excellent. Dr. Fabian, we don't have any more questions. I don't want to take more of your time. Dr. Fabian Gideon, Dr. Martha Mkonyi, if you have final words to say and things that we need to keep in our mind when we're leaving away from this training.
I mean, for me, it's just to remind everyone, hypothermia is bad on babies. So do the best we can, try to keep the baby warm. education to healthcare workers and the family when they go home that baby is cold at home and not responding to being swaddled or does not maintain temperature, even if they're covered, they need to come back to the hospital. Because as Lillian said, hypothermia could be a sign of sepsis. So if they go home, baby's cold, they can bundle them, wait an hour, check temperature. If it's still cold or baby feel cold, they need to go to a healthcare center.
If I can interject before I let Dr. Mkonyi finish up. So tell me, if I'm a mom going home, I just got the study instruction that I'm going home with a baby. And for me to know if this baby is having a temperature, I don't have the thermoscan or the temperature probe to get the temperature home. What are the things that I need to see to be like, oops, this baby needs to go back to the hospital?
I mean, one, you could try to feel. I mean, if the baby feels colder than you are, then the baby's probably cold. The other thing to mention to the family, baby who is not feeding well, they're probably decreased muscle tone. Baby could be cold. Baby who is just sleeping through feeds, they don't wake up to eat. They are probably not feeling well. They need to go back to the hospital. And then babies who looks blue, especially the hands and feet. If they're significant blue after 2-3 days, they are probably cold. They need to go to the healthcare center where they could check the temperature in the clinic. And if it's cold, then they could refer them to a hospital somewhere.
Okay, thank you very much. That's what we call discharge instruction. So for the healthcare worker, my friend nurses, when you're sending this mom and babies home, those are the instructions that you need to tell the mom or dad, whoever is available with the baby, to look up. Because most of the time when you say to take a temperature, now I don't have a thermoscan, I don't have something to get an objective number. So what do I do? So I appreciate that, Dr. Guido, for adding that part. So people just will be aware and what information we need to give these parents when they go home with these kids, so they can bring the child back as soon as they can versus bringing them when it's too late. Yes, Dr. Mkonyi, if you can give us the closing remark.
So I'll say don't ever forget glucose. That's the D part on the ABCD approach. So if we have means of checking temperature, like a thermometer, we also have means of checking glucose. And again, similar to like what as Fabian said, how do I know my sugar levels for my baby is less than, like I need to act on? Is the baby that is extraordinarily floppy and is not feeding? Your baby is not feeding, you are not happy. It's good to be worried and you reassured in the hospital rather than being worried and stayed at home and worry yourself as mommy and daddy. Well, there's somebody who is being paid to get worried, and that is doctors and nurses. So encourage your mom to do the mommy work and let the doctors and nurses to worry. And we worry if you see the baby is not feeding nicely, and then we can act on it.
So I want to thank you, everybody, Dr. Fabian Guido, Dr. Martha Mkonyi, for your excellent presentation.
You're welcome.
All the people who asked the questions and the people who are shy, probably hopefully next time we're going to ask those questions. Please just be brave. We can all learn from each other. Nobody is expert, but we want all those questions so we can answer and then make sure we improve our clinical practice. Again, thank you very much. We're going to continue offering these questions. And if everybody can unmute to all, show their videos so we can have just a gallery picture to have what people see faces who came to learn today. If you can, just for like 5 seconds, that's it. Thank you, Jafari. Thank you, Dr. Miriam Sambichaka. Thank you, Ms. Abela.
Bye.
Yes. Thank you, guys. Hey, Dr. Dina Kawakoma. She couldn't pay attention. Thank you very much for coming, everybody. I'm gonna let you guys go and be safe and work hard. We'll see you again in 2 weeks.
Thank you.
Bye.
Thank you.
Bye. Thank you.
You're welcome. Bye, Pira.
Bye.
Bye.
Thank you.
Thank you
Thank you
very
so
much,
much for
everybody.
inviting me.
You're welcome. You're welcome. So thank you very much. Bye, guys.
Thank you.